everybody knew about the iStent, and then iStent then moved into a second generation, which is the iStent Inject, which we then makes it far simpler to fire 2 stents into the trabecular meshwork to allow access to the Schlemm's canal. So the Inject became probably the #1 seller, I think, in the world of MIGS, particularly amongst the cataract surgeon, because of the ease of use that there is. There may be a little bit of difficulties in getting the 2 injects firing into the right place. You can see the surgical video. When you get them in the right place, you see the reflux of blood. But sometimes because it's quite small, you can overfire it through the meshwork. So hence, I am pleased about the latest edition of the iStent, which is the iStent Inject W, which is the one that with the wider back end. And the idea is that it's the same diameter and the same drainage capacity as the normal iStent Inject, but because it's got a wider back end, it stops it from being over-implanted through the meshwork. So I think, you know, that hopefully we're going to see iStent Inject really functioning to the true ability. And there's always been a little bit of argument against the Inject being that it's not as efficacious as one would like. And I am a much more fond surgeon of the original iStent than the Inject. And I'm hoping the W is going to change my mind a bit, because now you can actually correctly place 2 stents at the right place, stopping you from over-implanting. So I'm excited about the iStent Inject W, which I think will remain a big seller. They do have something on the pipeline called the iStent Infinite, which means that they can fire 3 of these things in one eye. And I think jokingly, you may say, well, just exactly how many of these devices you're going to implant in one eye before you are satisfied. So I think that 2 is probably a good number. 3 is kind of pushing it a bit. I think my primary ab internal device has been for many years the Hydrus microstent, which is a much bigger device that spans across 3 clock hours. And you can see the surgical video. It peers through the trabecular meshwork and actually goes into the Schlemm's canal. Then it's a bit like putting a cannula in the vein. Rather than having a single point entry or 2 single point entry that you get with an iStent, you're getting a much bigger entry and dilating and keeping that canal open for 3 clock hours. So from design point of view, I certainly felt that is a superior design and it should offer you superior efficacy. But then on the other hand, it's slightly harder to put in because it does require probably a little bit more of a steady hands and a little bit more surgical skill than firing the injects. But there are other ways to tackle the angle if you are keen to remove meshwork. Trabectome has been around for actually quite a long time. It was around before the iStent certainly landed in the UK. Now it's entering into a different generation, different company has acquired it. So now you have the trabectome, but then you can have also a simpler device, which is the goniotomy. So a simple, just removing the meshwork without the trabectome, which is a more complicated using a radio frequency blade. Or you can do the same thing, removing meshwork using the Cahoot Dual blade designed by Miley Cahoot in the States, which is a blade which is sold in the UK as an instrument rather than an operation. A blade is designed to harvest trabecular meshwork. So it's a double blade, you cut across it. And if you really want to save the 100 and something pounds of a blade, you can actually do the whole thing just using a needle. You can just use a needle and bend the tip and achieve similar thing. And I think now there's actually called the bend needle technique. I think it's actually called the bang technique. So there are cheaper ways to remove meshwork. And then if you're into dilating the canal, then we have the Alex, which is now Nova Medical, the ABIC, using the fiber optics. And I find this operation really satisfying and cool, actually. So this is a fiber optic that I internally now cannulate into the Schlemm's canal through the meshwork. You can see the flashing tip. And, you know, this is actually one operation that is satisfying to do for the very first time, because as a medical student, you learn about the Schlemm's canal, this mythical canal that goes around 360. No one really sees it. And this is for the first time. You can put a device into it and you can see the flashing lights on the outside of the eye going round, all the way back round 360 degrees to come back to where you started off. Towards the end here, you were able to see the flashing light coming back round 360 degrees. And, and I think to be able to do that is actually very satisfying that, oh, wow, there's you see the flashing light just there. Genuinely, we have a Schlemm's canal that in a lot of patients go around 360. And then you can then pull it back out and you can inject viscoelastic to dilate the canal, or you can pull the cannula right out to obtain a 360 degrees goniotomy. It's a fiber optic, and I think that a sister company came out and then now developed the Omni, which is kind of similar concept, but in a single hand piece. So then we now have this hand piece that you can advance this blue cannula that goes around 180 degrees. And then when you retract it, it automatically squirts out the viscoelastic. And then you turn it around, do the other 180 degrees. And if you want to pull it, you can use it to rip the meshwork as well. So Omni then taken the concept of ab internal cannuloplasty and goniotomy and goniotomy and combine it into a single hand piece. Omni seems to be doing quite well, particularly in the States, just because it's now in a single hand piece, which is handy. But it's worth knowing that the viscodilation ability of the original ABIG is significantly more, it squirts out significantly more Helon GV than the Omni does. So it's not really dilating to the same degree. So we'll wait and see whether Omni results is just as good as the ABIG. A very seems to be common operation that's coming back is just ripping the meshwork off, but using a suture. So this is the GAT. And I think GAT, a gonioscopy assisted transluminal trabeculotomy, GAT seems to be getting a lot of popularity right now, particularly in Europe. This is supplied to me by my good friend Sinjab Aktas, which I think is the queen of GAT based in Turkey. And she's very kindly lent me this video, and she's had a huge amount of experience with GAT. And I think GAT is certainly particularly popular, particularly maybe in countries where the health system is slightly different. The cost is more important. So this is a 5-0-proline, or you can use a 6-0-proline suture. You burn the tip a little bit to make it blunt, and then you ab internally using the VR forceps to thread it round. So this is the same as the eye track, without the fancy fiber optic, without the flashing light. So the flashing light is quite nice because you know you're going round, because sometimes you may find that your fiber optic doesn't go round and it dives down into a different channel. But you can see this one goes all the way around. And once you come all the way around, you grab hold of it. And then this is when you pull it to give you the cheese wiring effect and doing a 360 degrees trabeculotomy. You can do 180 if you want. You can do it round about here and then let go, but you can pull the whole thing to achieve a 360 degrees. And when you rip the meshwork 360 degrees, then in some patients, you are going to get quite a significant pressure lowering effect. You worry about scarring, and we'll talk about some of the downside, but GAT is certainly getting quite popular. So I want to give this talk surrounding about the EGS. This is part of the talk that I gave in the EGS. And, although I'm from the UK, which strictly speaking is, Brexit, but nonetheless, I think we're still part of Europe continent. And in the European guidelines came out, it's really for the first time this edition that MIGS got a slight mention. Not a huge amount, but it got a little bit. But these are some of the interesting comments from EGS, which I think that is something that I've been hearing from various colleagues over the last 12 years or so. MIGS tends to have a modest IOP lowering effect, but can reduce medication burden. And I think that's been repeatedly said, that your procedure doesn't lower pressure very much, it reduces medication burden. But it also, in the guidelines also state that the MIGS is not really in line with traditional aim of glaucoma surgery, and we'll come back and talk about that. But there's also insufficient evidence of superiority or even equivalence in efficacy between MIGS versus trabeculectomy. And that I hear all the time, your MIGS versus my trab. And again, we'll come to talk about that, where my own argument against these three statements and my view is, so when it comes to evidence and efficacy, MIGS was never really developed to be a trabeculectomy replacement or a trab killer. I think we'll make it very clear. I think people continue to maybe not understand that, or people who's very proud of their trabeculectomy And glaucoma has been a one operation specialty for many years until MIGS came about. MIGS was designed to lower intraocular pressure, not to the same degree as trabeculectomy, reduce medication, but we do it in a less invasive manner. So the efficacy has always been shown. And a lot of these MIGS devices go through the same FDA trial. So the original iStent, the iStent Inject, the MIGS, and the CyPass, which is the one who's been and gone, they all went through a very similar MIGS FDA study, which is we carry out a large number study, a huge amount, hundreds of participants, randomized 50-50. Well, it's not 50-50, but it's normally a 1-to-2 ratio that we're either comparing phaco versus phaco plus a device. And they are all teed up in a very similar way, mild to moderate glaucoma. And we have these sort of FDA study with the iStent, the Hydrus, and the CyPass, which is disappear. We don't have that with the Omni and the ABIC and the KDB knife. These studies takes millions to tee up, and all of them are 2 years FDA trial. And they all have very similar success outcome where they're looking for a 20% reduction in IOP, and we're looking at no medication. So be medication-free, 20% reduction. Most of them are designed very similarly. Medications are washed out, and then we have to have a significant pressure increase. So we're talking POAG, not normal tension glaucoma. You either randomize having phaco or phaco plus a device, and then we then see what the IOP outcome is. And then we wash them out again at the end of 1 year and 2 years to see the true effect. So ultimately, the success is that adding a device seems to increase your success. The overwhelming learning point is, number one, cataract surgery seems to repeatedly in all 4 studies do very well in pressure lowering, more than we would like it to do, more than what the company wanted. Overall, generally on the top rough figure is that 50% of these patients who's got mild to moderate glaucoma seems to achieve success with phaco alone, often off medication. So I think it's important to give that figure in your head. If you're a cataract surgeon, you can tell your patient with mild to moderate glaucoma, if I just do a phaco on its own, there's about 50% chance that we're going to get a significant pressure lowering and medication lowering. But if you add a device, you'll generally be able to increase your success. And the G1 increases success by about 9%. So rather than 50, you're looking at maybe 59%. The injects increase it by 13.4. So you're now looking at 60% chance. The CyPass increase it by 16%. And the Hydrus increase it by almost 20%. So I tell patients that basically, if you're going to choose to have a Hydrus stent over your phaco, with a phaco, if you've got mild or moderate glaucoma, you're on 1 or 2 drops, you're about a 50% chance you're going to come out, not only come out with a better pressure and less medication, but if you have a device on top, like a Hydrus, then you increase your chances of achieving that to about 70%. And I think that's where the success is. And again, like for like comparison, then you would think that the Hydrus seems to be the more efficacious, followed by the iStent Inject. And in terms of restoring back to normal IOP, again, phaco do quite well, but adding a device, you're much more likely to be normal tensive afterwards. And you see that with all the other devices. And in terms of actual pressure lowering effect by washout, you will find that the washout IOP shows that if you add an iStent Inject, you are getting an extra 1.5 millimeters of mercury lowering. So again, overall, top of your head, stick with the number 5. Like I told you, 50% cataract patients are likely to get a slightly better pressure and less medication. And you are likely to get around about, from the clinical study, about 5 millimeters of mercury lowering. That's a lot. And that's washout lowering. You're getting 5 millimeters of mercury from phaco, and you'll get extra 1.5 from the Inject, and almost 2.5 with a Hydrus. So again, the device gives you an extra, on average, 2.3 millimeters of mercury decrease in IOP. Now, those of you who do clinical study or write papers and do stats will realize that an average 2.3 millimeters reduction out of a 300 patients is actually quite a significant drop. To actually be able to lower the mean by 2.3 is quite significant. So your device offers you more IOP lowering. And in terms of the Hydrus, it gives you an extra 40% of patient being medication free. So yes, EGS is correct. MIGS tends to have a modest IOP lowering. We're not talking dropping the pressure by 10 or 15 millimeters of mercury, but it can reduce medication burden. But we should not look at that as a negative way. We should look at it as a positive way, because there are loads and loads of patients on loads and loads of eye drops. When I first started the MIGS, the eye stand, the joke from my colleague is always say, well, Leon, your operation help grandparents or grannies get off drops, and that's about it. It doesn't save sight. And I think that's correct. If you're losing visual fields, you've got advanced glaucoma, you are wasting your time putting in a MIGS device, certainly an ab-internal device. But these devices are primarily aimed to get your granny off drops. And there are lots of granny on drops. And once you've done some of these and get people off medication, the happiness that you tend to get from this patient is quite tremendous. You will start getting a lot of gifts because you get rid of these horrible eyes that you see now, glaucoma patient. You walk around a supermarket, I can tell you which one is got glaucoma because of these eyes, particularly if you like your bimetoprost. Please take it from me, try to move away from these medication. They give you the horrible dark sunken eye. So getting people off drops is not a bad thing. It's a good thing. So the Hydrus, for example, I keep going on because this is one of the only device, and I choose it because it has long-term outcome. It has a randomized control trial that I showed you before, but it ran all the way to 5 years, and I was part of that. This is the 4-year outcome that was presented in EGS, and in fact, 5 years is coming out. We're just about to present that in the SCRS and EGS and so forth. But just to give you a flavor that these devices, even running out to 4 years and the 5 years results very similar, it continues to hold true. Phaco do pretty well. 40% of the people remain medication free. So again, big up for cataract, big up for cataract. But if you do add a device, will consistently do better. So, and I think that this is what you offer the patient, that you consistently, up to 5 years, we're still about 65% of the patients, 4 or 5 years are medication free if you add a Hydrus stent. And everybody want to talk about endothelial cell because of CyPass, and I can tell you that certainly based on the Hydrus, the endothelial cell loss, there is none. You have an initial cell loss from your cataract surgery, and a tiny bit more when you have to spend an extra 2-3 minutes putting a Hydrus stent. And then afterwards, there is no added cell loss. And I would believe that the iStent inject will be equally safe because it's a smaller device. So we know they're safe. We're not entering into that CyPass era where the big stent is sticking out, damaging the endothelium. But this is the exciting thing, that for the Hydrus, this is really the first time, having run a clinical RCT up to 4 or 5 years, at 4 years, we have seen for the first time adding a Hydrus stent significantly reduce your chances of needing subsequent trabeculectomy. That's a big thing. That's a big thing. People think we're just getting people off drops. We're not. We are reducing your risk of needing subsequent trabeculectomy by a significant amount. It's a 3-fold increase if you just have phaco alone. So now adding a device is not just saving eye drops. We are saving you from having a trabeculectomy in the future. That's a big deal, big deal. And the even bigger deal, which has just been done by my very good friend Ghazali Moorfield and recently presented, and this is for the very first time, we are showing that if you add a Hydrus MIGS device to phaco, you're lowering your risk of visual field loss. And this is huge. Everybody said, Leon, I'm not interested until you got longer term data. We have longer term data. I'm not interested until you tell me your operation saves people from needing subsequent surgery. We have shown you that. I'm not interested until you tell me that your operation stopped visual fields getting worse. This is the first time we're showing a MIGS device is actually reducing your chances of visual field loss at 5 years. This is huge. And this, you can't fake this, because you can't fake this. You can tell, you can argue that I can fake all the IOP measurements in a clinical study, and I tell you that that's not possible because it's an FDA study. It's actually illegal to do so. But you can't fake the visual fields. This is just extracting all the visual fields independently by Gus and his team and analyzing that. And this is phenomenal. So lastly, we ran this for the very first time, a direct comparison RCT comparing iStent to the Hydrus. And this has been the long discussion, like which one do you choose, Leon? And I chose the Hydrus for the reason of this study that we ran and comparing standalone, no phaco, Hydrus versus 2 iStent. And it did seem to show that Hydrus is just that little bit better compared to the iStent. So if you want to base on the science, there's nothing that beats the Hydrus at the moment in terms of what's been published. And even based on Cochrane and Cochrane review, you can't argue with Cochrane. And Cochrane has looked at many devices, the Zen, the iStent, and the Hydrus and other devices. And Cochrane generally is pretty tight, pretty strict. They don't give you a good review. They don't give you favorable outcome unless generally it's rather lukewarm. And most of the MIGS devices has come out being rather low quality evidence. And actually, Cochrane, for the first time, the Hydrus has been shown that generally in mild to moderate open angle glaucoma, please remember that is the important mild to moderate. Then there is moderate certainty evidence that the Hydrus is adding something extra to phaco. Now, that is high praise coming from Cochrane, moderate certainty. The only reason it cannot be high certainty because the study is ultimately commercially funded, not independently funded. So this is getting a Cochrane support that the Hydrus is worth having over phaco. And also there's moderate certainty that the Hydrus is more efficacious than the iStent. So if you want to base on the evidence, you would choose the Hydrus. But you want to base on ease of use, then iStent at the moment is probably still coming out on top. And I'm going to pick up for the iStent because having been doing this for quite some time from the first generation. So we published this some time ago. This is looking at the longer term results of the phaco iStent. This is the first generation iStent. The phaco iStent, we follow these patients up over 7 years. Sure, the number tends to drop down a little bit. We have about, I can't remember, 30, 40 patients. We follow them for 7 years. And you can see that the IOP lowering effect seems to be pretty consistent around about 16, 17, which is what you tend to get with all the MIGS procedure. But the important thing for us is that we find that the vision is improved because we did a phaco. Cup-disc ratio is not changed. Visual fields have become stable and they've not deteriorated. I'm not letting these people rot. But interestingly, 7 years before the operation, these people are generally being seen in the clinic up to 2-point-something times a year. After the operation, within the first year, we saw them a few times because of the post-operative visits. And then gradually, the patient is being seen far less often, only 1-point-something times per year. So this is the first time we can show that our MIGS procedure reduces the need for the patient to be reviewed. And for us, that's a bonus. If you work in a health system where capacity is a problem, then we're reducing the need for follow-up because these people are doing better. They're not getting worse because our fields and disc and the VA is not dropping, but they're reducing the need because our pressure is being better. Again, this is some results published by the Queen of GAT, Sinjab, my friend, in terms of GAT procedure in open angle adult patients. Again, we're getting a substantial drop in IOP and a good success criteria, good success percentage up to 80-odd%. If you look at the IOP drop, to be below 15 is 60 to 62%. Below 18, 77%, below 21 on normal intensive is 90%. So it seems to have a pretty decent success rate. Whether it will be as equally successful 5 years down the line, being a more traumatic procedure, we'll wait and see. We're getting down to the pressure around about 15, 16, and that's what you're going to get with an angle-based surgery. I am not convinced, completely biased personal view, that an angle-based surgery is going to get you 10, 11, 12. Whenever I see those, it does make me question it because your drainage system physiology doesn't really get you down that low. There's a flaw based on the outflow resistance and the episcleral venous pressure. So 15, 16 is likely what we're going to get at the angle. The GAT, I'm not I do some. It's not been my procedure of choice. It's not something that I would particularly do on my mother if they're just coming in for a phaco and they're looking for a nice, clean phaco, a bit of toric lens, a beautiful refractive outcome, because of the risk of hyphema. I mean, Zinab's paper, there's 28% hyphema. I mean, that's more than 1 in 5. And to be able to do a combined phaco gap and then the patient be hand movement or count fingers for 2 weeks is in a different setting. It can be quite distressing. While people will say, well, you know, my neighbors had a cataract surgery and she was seeing beautifully and driving the next day. So it does require some careful counseling. And I'm worried about this hyphema and the pressure spike that you can see afterwards. 1 in 5 patient has a pressure spike. And compared to a hydrous device, it actually has been shown and published that by putting in a hydrous device, your pressure spike first day is significantly less compared to phaco alone. So GATS is potent, but it's probably giving you some more complications. But it's cheap, so economical, and that's a big deal. Now, this is something that is coming out and is new, and I have not got my hands on it. I'm hoping to start. So why do we remove meshwork using an excimer laser? And I think that excimer laser has been around for a long time, and I'm hoping this video will run. This is excimer laser trabeculotomy. So basically, we're going around ab interno using an excimer laser to create multiple opening to allow fluid aqueous to drain in. So this is not thermal, this is not mechanical, this is excimer laser that people well know. We're creating multiple entry. So rather than shoving an ice and inject, we're doing multiple opening, but we're not cannulating, there is no device, and there's not much bleeding with the excimer laser. So then that seems to be quite attractive, and we'll wait and see how that one turns out. But this is how it looks. So you can almost see the pearly white Schlemm's canal behind it, and multiple opening. And if you push onto the eye, a gonio-induced blood reflux, you can see that. Without a meshwork, I think you have got some concern whether you're going to get some reflux and get some hyphema, but the hyphema rate is going to be lower than pulling the meshwork in a gap procedure. And this is some of the results. One of the paper by Marino, we're getting the usual 15, 16 pressure, significant reduction in medication. So that's what the efficacy of angle-based MIGS is. Mid-teens pressure, significant reduction in medication burden, which for me is a good thing to have, combined well with phaco. I think EGS can look at it and say, well, your MIGS, this benefit is not in line with traditional aim of glaucoma surgery, and that is interesting. And I'm going to challenge that maybe a little bit old-fashioned in terms of what is the traditional aim of glaucoma surgery. Well, traditionally, we only have one really glaucoma surgery, which is trabeculectomy. I'm still a big fan of trabeculectomy. People seem to mistaken that if you're a MIGS surgeon, you don't do traps. And certainly for me, I do a large amount of traps. You know, I still do, 3-4 traps per week. But the patients groups are different for MIGS. And trabeculectomy is very good when you've got advanced glaucoma over here with terrible field loss. There is no argument in my mind this patient needs to have a trabeculectomy, not anything else. But is trabeculectomy really good for a patient who's got very high pressure but normal? This, like an ocular hypertensive who's measuring at 35 all the time, despite medication. You can't get it down, but there is no glaucomatous damage. Is trabeculectomy really the way forward for them? A rather invasive procedure for ocular hypertension? Or how about those patients who just cannot put any eye drops in? Everything irritates them. Everything causes them a problem, but they don't really have much glaucoma. Are you going to trap them? Or how about when you've got concurrent cataract? And phaco trabeculectomy is not being a great operation. It's a poor cataract and a poor trabeculectomy. So it doesn't combine well in my book. So that's where MIGS comes in, that in this situation. And also, if you look at EGS, then when you're deciding on glaucoma surgery, then patient's preference should be taken into consideration. Well, patient preference is very interesting nowadays. And this is a lovely study published in Eye. This is actually a survey amongst American glaucoma specialists. We asked them, if you had glaucoma yourself, what would you like? If you got uncontrolled glaucoma and your field's getting worse, what procedure would you like to have on yourself? And surprisingly, trabeculectomy did not come up top. MIGS procedure came up top. Because between you and me, we all know that none of us really want to have a trabeculectomy on ourselves or want to have a bleb if I can do without. And I think that the problem is that the common problem in glaucoma management I see nowadays, we are very good at traps. It's not about the traps are bad, we are getting terrible trabeculectomy, we're getting terrible leaks and endophthalmitis or blebitis. I think those are actually far and few between. I think the common sin that I see in my practice are the patient came to see me because people are still reluctant to go and operate on them. And they are just on way too many eye drops, 5 or 6 different eye drops, and they're getting these horrible brimonidine allergies, uveitis, and they're letting them to cup out gradually because no one really wants to operate on them because they're worried about doing a trabeculectomy or doing any surgery. And I think MIGS allow us to intervene earlier than dropping the patient to death with operation, with drops. So we have the bleb-based procedure, as I mentioned before, traps and MIGS. So if you talk about a trap in a minimally invasive surgery style, then devices like Zen implant was meant to be. So this was acquisitioned and then was sold by Allergan. Zen was the first ab internally inserted stent to create a bleb. And the idea is that whether in ab internal, without opening the conjunctiva, we go across the anterior chamber, as you can see here, and then we're using an injector to inject this little gel stent to drip the aqueous into subconjunctival space to create a bleb. The Zen, I think that is still around in a lot of countries, but I think that certainly in the UK and many European places, the Zen is gradually being phased out because we have now moved on to the PreserFlow by Santen. And I think the PreserFlow has taken some time to come, which is kind of using a device to create the drainage, but we are opening the conjunctiva and the tenon like we do in a trabeculectomy. And we are understanding that, having been through the journey, take it from me, opening the tenon and conjunctiva is a key in success. We have to be able to put these devices under tenon and to create a nice looking bleb. And then, but rather than cutting a flap and putting a suture, and that bit is the variability. Everybody does it differently and you make a different result. We're replacing that bit with a simple device that has a fixed flow rate. We get that variability out of the way, and then all we have to do is put it in the right place and kill off the conjunctiva fibrosis by using a heavy amount of antifibrotic mitomycin C. So the Zen, we've had this multi-center 2 years. In fact, we have 3 years results published, and it seems to be breaking that 15, 16. For Zen, we're getting down to around about 14 mark, which is not bad. A bleb-based procedure, getting a 14 mark, significant reduction in medication. And I think that microshunt, again, seems to be getting the 13, 14 mark. My impression is that the microshunt definitely is a better, more efficacious operation than a Zen, much less needling and looking after. It's no trabeculectomy, okay? Trap still gets it down lower. And in fact, the microshunt versus trabeculectomy study, 1 year outcome certainly shows that the trap gets down lower than the microshunt, than anything else for that matter. But you don't necessarily buy a supercar just because to buy the fastest 0 to 60. There are many other factors when you're picking your nice sports car. Not everything is a 0 to 60 race. So when glaucoma surgery, not everything is about getting you as low as possible. For an advanced glaucoma patient, yes, it is about getting as low as possible. But safety features, comfort, ease of use, availability, and how much it costs, just like a car, comes into practice. So for the microshunt, for me, the sort of bleb we're getting is beautiful. We've never really been, this is one of the best looking bleb that we've had, and it's pretty consistent. And this one is just done by my my trainee, my resident under supervision. And you can't guarantee you that a trap's going to turn out looking this good, because sometimes you're just unlucky. You're getting a rather ugly looking trap and a rather cystic looking bleb. And for a micro shunt, for example, I certainly find it very compatible with contact lens wear. And you can't really say that about trabeculectomy. So it's not a trap killer when it comes to IOP, but I think personally, I probably would prefer to have a micro shunt if given half a choice when it comes to the bleb. So I think there's no weekly visits, there's no bleb manipulation, there's a lower risk of hypotony, lower risk of discomfort, and it combines reasonably well with phaco. So overall, micro shunt has replaced a lot of the trabeculectomy, especially during COVID time, when we really want a do and forget operation. So there you have it. We have such a wide variety of surgical procedures. And sometimes that gives people a negative view. It's like there's too many, Leon, too many. And I think you're correct that having choices, I think, is good. But nowadays is almost as hard deciding or understanding which one to go for than actually learning to do the operation. But don't blame the choices. The fault is always in the choosing. And I always feel that sometimes we choose the wrong thing for our patients. And this is one of my contribution, if you like, and my own take on things. You will see these slide time and time again, very common, that we talk about glaucoma in a linear fashion. Mild glaucoma in one end, severe in the other. And the mild end, you start with drops, and then you do a bit of SLT. And then this is when you come in, you do a bit of mix in the middle. And if it doesn't work, you go for a trap, and then you go for a tube. I'm going to challenge you that I believe this linear approach is wrong, because in real life is not linear. And I think at least we should look at it in two directions. And the horizontal axis for me is the disease. You can have mild disease in one end and advanced disease in the other. But on the vertical axis, we have complexity. We have simple at the bottom, but a complicated eye at the top. And I think that's important to have it in your head, because I can have a mild disease, i.e. someone who hasn't got much optic nerve damage or visual field loss, but the eyes could be very complicated because they've had multiple vitreoretinal surgery, cryobuccal, or they've got mucus pemphigoid. That's a complicated eye running a pressure with mild disease. And the approach for that will be different than someone who presented late with advanced open-angle glaucoma, really bad disc, really bad field, pressure is 35, but they've never been on drops. Well, actually, if it's an open-angle glaucoma, that is actually quite a simple eye to deal with, but it's got advanced disease. And that makes it different. So for me, when you look at, this is my take on things, then I think that is the end where SLT and medication comes in. Reasonably mild disease, whether you are simple or complex with multiple pathology, difficult uveitis, drops and SLT at that end is pretty good. But if you've got bad advanced disease, then we tend not to be going with the drops and SLT. Trabeculectomy sits here, which I think is advanced disease, from simple to moderately complicated. But when things get difficult and complicated, because they've had multiple surgical interventions and so forth, then trap is not going to be your one to go for. But trap is really good for advanced disease because it gets your pressure low. So I think that's where trap sits. And I think this is where canal-based MIGS sits. Reasonably mild to moderate glaucoma and reasonably simple eyes to moderate eyes, nothing too complicated. And this is where the clinical results are, the clinical trials are, and that's where canal-based surgery should sit. And you shouldn't really think about it as your surgery of choice in someone who's got advanced disease. You can certainly do it if they've got advanced glaucoma and they're coming in for a cataract. There's not much harm in doing it for an advanced patient. But if you talk about stabilizing the glaucoma, that's where canal surgery sits. And I find that bleb-based device like the Zen and the PressiFlow sits like that in a slanted angle. I say that because down here, then I find that You can use it in more advanced disease, but if I do, then that eyes has to be reasonably simple. The conjunctiva needs to be mobile, reasonably virgin, and not been on 10 billion eye drops for 10 billion years. But if I'm happy to use it in a more complicated situation, like up here, people who's had a failed trap, people who's had a cornea transplant, for example, I'm happy to do that. People who's got peripheral ulcerative keratitis, but they have to have reasonably mild disease, because if their eyes are complicated, then I'm not likely to get the pressure that low. So the disease needs to be mild. So I find that the bleb-based procedure is slightly slanted. And last but not least, this is where tube sits for me at the top. Complicated eyes for a whole range of disease, whether it being mild or advanced, some of them just need to have a tube because they're so complicated, nothing is really going to work. So that's my take. And I think that the last slides for me is probably the most important message I want to get through. So yes, if you work in Europe, then we finally MIGS gets a bit of a mention. I think the evidence is gathering for ab internal MIGS. We're seeing 5 years outcome from Hydrus, and I think that is very exciting. Then MIGS surgery help to reduce medication need, reduce the need for monitoring and follow-up based on our long-term follow-up results, and reduce the need for you to need to have a trabeculectomy. For you, is that acceptable for you? For me, that is certainly an acceptable outcome for these devices. And the only argument that we really need to have in our head is how much should these devices cost? The price that we're going to pay for those benefits. And I think that we're going to have to continue to have a debate, but we can't debate that until we see some of these results which is coming through. And I think the most important thing when it comes to MIGS is how you choose and what you choose. And how you choose is probably more important than what you choose. Ultimately, a lot of the angle-based surgery is pretty similar. And a lot of the bleb-based device is pretty similar. But how you choose on which patient is all probably more important than particularly which device you choose to use. So I'm going to stop there, but thank you very much indeed for listening to me.
Thank you very much, Leon. That was fantastic review. I personally learned a lot from you, as usual. Thank you very much. If you don't mind, I have a few questions to ask, and then I will move to the audience question as well. So regarding the Hydrus, as an expert in MIGS, have you abandoned the eye stent from your practice completely, according to that, or you are still doing it in some cases?
I think I think overall my preference is if I can get a Hydrus in, I'll get a Hydrus in. I think that the eye stent, the injects, I still have it, especially the W. Completely on a personal note, then some of the angles, I think, despite being open, it's just a little bit too small and crowded, possibly for the Hydrus. For example, if the eye is a bit short, axial length is a bit short, or if they got previously somewhat narrow angle and you're doing a phaco and you want to put some device in, then I think that probably putting in an eye stent is probably still some benefit, while getting the Hydrus can be difficult. But by and large, if I could get a Hydrus in, I'll get a Hydrus in.
Perfect.
Based on the science.
And,
based on the science.
Yeah, I completely agree. And is it suitable for people who are on blood thinners, like warfarin, abixaban, these kind of things?
Yeah, the blood thinner never really came into our world when it came to cataract surgery. And not even then when it came to glaucoma surgery, because we have the beauty of diathermy. We can stop bleeding before we finish. Now with the devices, with the GAT, and with the pressure flow, when we're shoving things into the eye without diathermy, we're seeing hyphema again. So you're correct that blood thinner does worry me. The new generation of blood thinner, like all the apixaban and all that thing, then is a problem. So I think one should carefully think about stopping some of the new generation anticoagulant if you can for 2 days. And I think apparently that's okay. Aspirin, if you can stop, I'll stop. Warfarin, I never have the guts to stop, so I always operate on the lowest end of the acceptable INR range. And if the combination is that they are hypertensive, the blood pressure is high, and they are on a massive blood thinner, then yes, I may not want to be doing a gap procedure because I think I'm going to bleed a lot. I may be considering an eye stent, which I think is less likely to give you a bleed. So we have choices, and I think we need to think about things like that more carefully.
Perfect. And the other thing about hydras for people who haven't started doing it yet, I think it's always a question in our mind. If you put it in a wrong way, and if it's touching the cornea, how complicated it is to remove it?
I think the intraoperatively is quite easy to remove, because the device, once it delivers it, you can just go and grab it and retrieve it back into the device. So I think the design is beautiful. So you can retrieve it back into your device and you can use it again. I think you would probably never insert it too high up that would touch the cornea. It just wouldn't go. There is no anatomical space. But you can certainly go too low and it dips down into suprachoroidal space. So the diving down hydrus will happen to just about every single hydra surgeon. It will happen. You can retrieve it very easily and go somewhere else. So I think it's not as hard as maybe people make it out to be, or people will worry. But I think because the science and the efficacy is certainly there, then I think it's a bit hard to argue not choosing it based on the science.
Okay. And regarding the PreserFlow, please, would you consider PreserFlow for quite myopic, very myopic patient, like -12, something like that? And would you do anything extra in these cases to prevent?
I think you certainly, I think you're coming to the point that about getting the risk of hypotony. I think that I would consider a PreserFlow. So I think that like a high myope, has always been a risk of hypotony after filtration surgery. In trabeculectomy, it could happen because you may find the sclera is a bit thin. So when you cut a flap, the flap could be a bit thin, and then you're not be able to secure it very well to get postoperative hypotony. And with the PreserFlow, then you can argue that the flow is constant. So you're not going to have a badly cut flap, and your sclera thickness doesn't really come into it. So we should get a steady flow. So you should get a lower risk of hypotony. But then we know that myopic eye, just even if you drop the pressure a bit, they collapse a bit easier. So kind of swinging around about. So I would still choose a PreserFlow. And I think that my hypotony rate is genuinely very low. I think that you probably, if you join some of our PreserFlow webinar, you will hear some of us is now putting a nino suture into the PreserFlow. Yeah. So we are now putting a nino suture into the PreserFlow so that we reduce the flow even more. And that suture comes out like a releasable suture. And then we can pull that out a week later. And that is a great little tip, because then we're now getting a titratable PreserFlow. So that is something that I would put in a very high myope or in a uvitics.
And do you have any specific post-op protocol? Just to give you an example, in Coventry, what we do is we give subconj dex week 1, and then subconj 5 a few week 2. Would you agree on that, or do you do something
different? And
different?
that for your PreserFlow?
Yes.
I know there are people who will support you. It's not something that I do. Ultimately, my trap, I feel that my trap's very good in terms of results. I know that everybody's trap is very good, but I am choosing not to do a trabeculectomy for PreserFlow, because I like the fact that I get a good predictable looking bleb, and I like the fact that I've got low maintenance. I see them at 1 week and I see them at 1 month. If I have to see them 1 week, 2 weeks, and I have to inject the patient at 1 week and 2 weeks, I don't even like it for my traps. And the benefit is not there, that it should be low maintenance. And I'm not really find that there is a need for it. Again, you pick your patients well. I'm not going to pick a red eye. I'm not going to pick a patient who's on 5 medication. I'm going to pick someone who's got a nice conjunctiva. And I use, as you probably know, consistently 0.5 mitomycin C for every microshunt. 0.5, whether you're white, whether you're brown, whether you're black, whether you're Chinese, they get 0.5. And that the only key I've always said is that you must have tenon. So I find the tenon and I put the 0.5 mito underneath the tenon. And I honestly don't really feel there's a need to do much manipulation. And that is the benefit. If I'm not getting that benefit, I have to see them and inject them regularly, then I'd rather do a trap, because I don't inject my patients regularly with a trap.
Perfect, perfect. And lastly, when do you go for viscodilation over trabeculotomy, like removing the internal wall of Schlemm?
Yeah, I don't know. The answer is, and I honestly don't know. And I think that we have yet to really fully understand and know the effect on a ab internal dilation. And I think that this is probably what's coming in the next few years, the ab internal dilation with the eye track and the Omni, and they are not the equivalent, despite what Omni may say they are. They're not. Omni, eye track gives out 20 to 30 times higher volume of viscoelastic than Omni. Eye track will say Omni is barely lubricating the canal. They're not dilating at all. And in terms of dilation versus ripping of it, and we don't know. And I think some of the clinical study we're now starting to do will compare that directly. There are authority that will tell you that trabecular meshwork is a beautiful thing, we should not rip it. And there are people who's been dilating canal ab externally for their whole career, and they feel very strongly about viscodilation. I would love for viscodilation to work well. And I'm not the biggest fan of ripping the meshwork, especially 360 degrees. I think the complication really puts me off. I just nothing worse than doing a glaucoma procedure and the patient is hand movement for 2 weeks. Really put me off.
True.
It's just bad, and we never had that before.
I agree completely, actually. I think we have actually one question from the audience. Is secondary glaucoma like pigmentary glaucoma, in cases of secondary glaucoma like pigmentary glaucoma, which MIGS would work better, Cahook, blade, or hydra stent from your point of view?
I would probably say both, but I think the Cahook sounds, a removal of the meshwork sounds like a good thing. So this is when I tell you that if you remove the meshwork like a Cahook or a GAT in the pigmentary glaucoma patients, in the uveitic patients, or in people who's got juvenile onset open angle glaucoma, we believe these people, pressure goes up because of bad meshwork, not because of bad canal or bad collector channels. That removing the meshwork really is very powerful. So a pigment dispersion coming in with a pressure of 40, and they often do, if you remove the meshwork with a Cahook or a GAT, you will get a phenomenal drop. Because I think those patients, the downflow, the canal is pretty healthy. The downside you're going to get is that they are going to bleed. So you're going to tell them that I'm going to do this, you're not going to see well for 2 weeks, and suck it up. So yes, I think removing meshwork in those patients is very potent, which is why GAT is the primary surgery for pediatric congenital glaucoma now, because the meshwork is abnormal by removing that. So yeah.
Yeah, and thank you very much. One last question from Dr. Obada. Do you have experience in iStar Miniject? What do you think?
I don't think anybody has any experience apart from the patients in Panama and India, where the studies are being carried out. I've had, the only experience I've had is that I had put it in a plastic eyes and I have looked at the data. I've had conversation with the company. I would love it to work. I would love it to work. I would love one day to have a suprachoroidal device that actually work. But in the history of glaucoma, a suprachoroidal approach has always failed all the way back from creating a cleft to shoving a piece of plastic to putting a piece of horsehair in the 18th century to the solid gold shunt, the CyPass, and now the iStar. But I do believe that if you get the right material and the technology, is a potent space. Whether as a community we have an appetite for it because of CyPass, I'm not so sure. I'm not so sure with the different modality that we have. I don't know whether we have an appetite anymore for a suprachoroidal device and the risk that comes with it, which is hypotony and a cleft and the pressure spike. Doesn't matter what they tell you, that happens in a suprachoroidal device.
Perfect. And this is, believe me, this is the last question again from me, actually. It's if you have failed preserved flow, would you choose to go for needling or revision, or just abandon the whole thing and go for tube?
So I would not needle. I almost never needle my pressure flow. So again, compared to the Zen, which was needling them to death, I published a 45% needling rate, which is not that high, which is the average. We dropped it down gradually, but I don't needle my pressure flow. The only one that I would needle is when they got a beautiful bleb and the pressure has been 10, 10, and then suddenly they came back a bit encapsulated. I caught them on in time and the pressure's gone to 20. Then I may poke it a bit. Otherwise, I don't. Generally, when the pressure flow is not working for me, there tends to be a lowish, not much bleb. Then I would think about a revision. I will think about a revision if I think a revision is going to do it. And the reason being, maybe the pressure flow is too superior, which is draining up against superior rectus. I always say that's a bad thing. So I think the pressure flow should be superior nasal. So if I think it's butts up against 12 o'clock, then I think, okay, a revision and moving it is a good idea. If initially I didn't put enough mitomycin C because it was one of my earlier one, I used 0.2, then I think I would revise it and slap more mitomycin C on. If I thought that the microshunt was actually a bit blocked because it was butts up against iris, then I would revise it. But if it was somebody who's worked really well but gradually failed and her glaucoma is getting worse, the disc is getting worse and the fields are getting worse, and I don't really want another disappointment, then I would probably not bother touching that and go for a secondary procedure, which will be a trabeculectomy, not a tube. So yeah. So because I put my microshunt superior nasally, then you can do a trabeculectomy. But I would take it from me in a personal experience, having trapped some of the Zen and some of the microshunt, I think that we are slightly higher risk of getting some complication from that trabeculectomy. And I think it's true looking at the data, the trap tends to run a bit low if they've had a previous Zen. I think that's probably because the tissue has been exposed to mitomycin C. So when you come to do your trap, you find the sclera is a bit softer. The conjunctiva doesn't heal so well. So bleb leak, hypotony, overdrainage becomes more of an issue. And that is true. I think Moorfields looked at their results and it shows that trap after Zen tends to have a higher risk of hypotony. And I feel that trap after pressure flow, there's a slightly higher chance of hypotony. So I do need to tie my trap down a bit better and close my conch a little bit better.
Actually, thank you. That's gold. All your advices and tips. It's really, really very useful. Thank you very much. Thanks, Leon.
You're very welcome.
To you. Thank you.
Oh, great. Dr. Munir, did you see all the questions? All the questions were asked?
Yeah, I think so. I can't see any more question unless if I missed anything. Yeah. Actually, there's one question appeared now on the question. What is the best management choice for the conj leak after DS surgery with mitomycin?
You mean a deep sclerectomy? They always tell me they don't have complications. And I think if you've got a conch leak after filtration surgery, deep sclerectomy is one of them. I'm sure that you have a different view, Munir, but for me, if it is leaking, nothing beats another 10-0 nylon to close it. So take them back to theater and close it. Unless it's a late leak, unless your conjunctiva is really avascular and is leaking 3-4 years down the line, then in that case, that's slightly different. But if it is initially post-op period and is leaking, then forget about your bandage contact lens, forget about your double pad, just take them back to theater and put a stitch back in.
Perfect.
Then everybody sleep well.
True. Thanks a million. Thanks, Leon. That's really very useful. All the tips. We really appreciate this. Thank you very much.
You're very welcome.
Thank you, Leon, for this comprehensive overview of the MIGS and very detailed, actually, and for your time that you devoted for this lecture. Really, we appreciate the acceptance of the invitation and the great science that you have taught us. So thanks as well to Munir for the great discussion as well, and for the audience for being with us, and have a good night for everybody.
Have a good night. Thank you.
Thank you.
Bye.